Hello, everyone. Thank you for the nice introduction, and thank you for the organizing committee for inviting me for this lecture. Today, I'm going to talk about the role of radiology in diagnosis and management of the CKD, MBD, the chronic kidney disease mineral bone disorders. I'm going to focus first on the plain X-ray film that we usually try to ignore or not focus on these days. And then we'll talk about the quantitative ultrasound, DEXA scan, quantitative CT, and the high resolution peripheral quantitative CTs for evaluation of the bone strength. So let's talk first about the X-ray. X-ray actually can give you very important information, the plain X-ray, about the bone health and strength of our CKD patients, starting from osteopenia and osteoporosis. Of course, the patients have to lose about 30% of his bone before you see an evidence of osteopenia on the plain X-ray film. So it's not sensitive, and it's late, diagnosis if you see any evidence of osteopenia in the plain X-ray film. This means that the patient lost quite a bit amount of his bone. Of course, fractures, we can evaluate the fracture by plain X-ray film. Then I'm going to talk about, just some of the X-ray findings that you can see. As you see here, there is a lot of findings, including osteosclerosis, subperiosteal bone resorption, acroosteolysis, Roger-Jersey spine, sacroiliitis, atypical femur fractures that can happen after prolonged use of bisphosphonates in CKD patients, brown tumors, rickets in children, secondary tumoral calcinosis, chondrocalcinosis, and of course, soft tissue and vascular calcification is another big topic that we can talk about maybe in other lecture. Then of course a vascular necrosis of the hip that can happen after use of steroids. So let's focus here on this X-ray film of a patient on dialysis. You can see this osteosclerosis, and also you can see this area of lucencies. So this is called the ground glass dynasties or appearance of our dialysis, skull patient. And on the other hand, you can see the salt pepper sign in this patient. So there is area of sclerosis and there is areas of lucencies here because of the bone loss, then the bone formation that can happen to try to replace the bone loss. This image was published last year in the New England Journal of Medicine. And I used to see this, in Egypt before I moved to America many years ago. Not rare, I see this morphic features with this mandibular enlargement. We call this brown tumor or osteoclastoma. And also it's big, but it's very soft, it's very lucent. And here is another image of osteoclastoma. So osteoclastoma happen mainly, or brown tumor happens mainly in the flat bone, like skull and ribs, but also happen in the long bone. You can see it here in the fibula. You can see it here in the metacarpal bone. And here you can see acroosteolysis. And also you can see that the radial aspect of the fingers has subperiosteal bone loss. And so even here you can see the distal part of the fingers in our dialysis patient can be lost. This is called acroosteolysis. And of course you can see the soft tissue calcification. And here is the subperiosteal bone resorption. In the spine, there is a very typical sign. You can see this called Roger-Jersey sign. When you see there is sclerosis in the interplate of the vertebrae, and here you can see the osteopenia or loss of bone or translucent area. So this, mottling appearance, when you see areas of different densities, this is called Roger Jersey sign. And of course, from the X-ray of the vertebrae, you can see also and appreciate this significant amount of aortic calcification. Here is advanced form of osteolysis. So the patient lost, a quite bit amount of bone and now end up by having, compression fracture of the vertebrae. And here is, aggressive compression fracture. And usually this patient actually have chronic back pain. They might be, very late when you diagnose this patient because they have non-specific, back pain. If it is ignored, the patient usually lose about 2, 3, up to 4 centimeters because of this compression fracture. So we have to be vigilant and we have to search for it because sometimes it's just silent and quiet. Another very, prevalent symptoms in our patient is pelvic pain and lower back pain that can happen because of the sacroiliitis that happen because of the chronic inflammation of the sacroiliac joint. And here you can also see the hip fracture. The hip fracture that happen in our dialysis patient, actually more than 50% of them will die within 1 year after having hip fracture. So prevention is better than cure because mortality rate is very high in this patient population. And here you can see KUB film and you can see the extensive vascular calcification. You can see here X-ray of the arm and you can see also here it's not venogram or arteriogram, it's just calcified blood vessel. And here extensive calcification, you can see this cannonball appearance and this is called secondary tumoral calcinosis. And this extensive form, usually the patient will have calciphylaxis and the mortality rate is very high in these patients. I think that's enough for the plain X-ray films. Let's move to other diagnostic tools. We have the Q ultrasound, the quantitative ultrasound. Of course, there is no radiation involved with this ultrasound, and it's usually done for the calcaneum. So, but also you can do it for the tibia and for the hand. It has moderate correlation with the DEXA measurements, and it's independent risk factor for fracture. It discriminates subjects with fracture, that can differentiate the patient who have fracture or not. And it's usually very good, it has very good correlation with the cortical bone strength. So it's associated with the proximal hip fracture, not usually with the spine fracture. It has similar sensitivity to DEXA, but of course, lower specificity. So the key DIGO guidelines, the selective update 2017, they mentioned that in patient with CKD, stage 3 to 5D, with any evidence of CKD MBD, and we know the evidence of CKD MBD, either laboratory or radiological, or if the patient have any evidence of bone loss, and if the patient has any risk factor for osteoporosis, and we know the risk factor for osteoporosis, including alcohol consumption, cigarette smoking, corticosteroid usage, poor ambulation with lower calcium and vitamin D intake, sedentary life, all of these are risk factors. Then they suggested to do BMD testing to assess the fracture risk if this will impact the treatment decision. So let's see what we can get from the DEXA. We can get, of course, the BMD, the bone mineral density. It's very popular and it's cheap, and the radiation exposure is very low. Of course, it's non-invasive and it correlates with the cortical porosity and the histomorphometry and dialysis patient. However, it has some caveats. So it's only 2D, so it's two-dimensional. It's areal density, it's not volumetric measurement, and it cannot differentiate between cortical and trabecular bone. It doesn't measure the bone size, And it can give you false positive results, especially if the patient has a lot of aortic calcification or osteophytes. And DEXA doesn't predict, of course, the type of ROD, so it doesn't tell you if the patient is losing bone because of high or low turnover bone disease. One of the most important things about DEXA is you can use the FRAX score, you can use a BMD and the software that gives you 10-year probability of fracture. So it's good tool to predict fracture. The problem with the BMD measurements, and of course, all of us know this, normal BMD is up to -1, then -1 to -2.5 is osteopenia, and less than -2.5 is osteoporosis. The problem is majority of fracture actually happen in patients with normal or osteopenic BMD scores. Of course, if you have lower BMDs, you will have higher chance of fracture, but still, even with normal or osteopenic ranges of BMD measurement, you still have risk of fracture. Because BMD doesn't give you everything about the bone strength. How can I evaluate my bone strength or my patient's bone strength? So we have to, discuss this briefly, this concept of the density and the strength. It doesn't mean that you have a denser, share or seat, that this denser, structure is stronger than this. So this seat is made of wood. This seat is made of metal. Of course, metal is more denser. When you put this on, machine, DEXA machine or X-ray machine, this will be, of course, more denser. But what happens if you play with the structure? If you take out the hinges, and the connection, despite that this, seat is less denser, but it will be stronger because the structure here is weak. So it's not only, so bone assessment doesn't include only the bone density or bone quantity, but it has to account for the bone structure, the bone quality, as long as also we have to focus on both bone quantity and bone quality. So to have a strong bone, you need good bone density. So your BMD needs to be at least within the normal range. And you have to have a good structure, microstructure, nanostructure, microarchitecture, better, good bone quality. How can we evaluate bone quality? It's a big topic, but briefly, there is a software. When you ask for DEXA scan, don't only focus on BMD, ask for TBS, trabecular bone score. These two patients has the same BMD measurement, but when you look to their vertebrae, they have different microarchitecture. This one is the microarchitecture here is much better than compared to this one. So the TBS, trabecular bone score, if it is more than 1.4, that's normal. It gives you impression about the bone quality, not only about the bone quantity by BMD that you get from DEXA, but also you can get some impression about microarchitecture. If it is less than 1.2, that's bad. It's, this is mean that the bone quality is bad, the microarchitecture is bad. And I want you to focus here because these patients, group A of patients, they have osteoporosis, right? So their bone density, bone quantity is bad. Of course, if they have also low TBS, bad bone quality and bad microarchitecture, this patient will have the highest risk for fracture. On the other hand, this green box, this patient has, on the other side, normal BMD and normal TBS. So this patient has the lowest risk of fracture. But compare C and D. C is osteoporotic patient, but has good TBS. And D is patient with lower TBS, but they are not osteoporotic. And still D can fracture at a higher rate compared to C, despite that D, they are not osteoporotic, but this is probably because they have bone microarchitecture problems. TBS correlate with the fracture risk. It helps to better predict the fracture, combine both BMD and TBS, the trabecular bone score, for better understanding of the bone strength and prediction of the fracture risk. It doesn't only help you in diagnosis, but also in management, because there is differential response to medication. Like you give the patient Forteo, the BTH, it's very good to improve the BMD about 10%, but it only improves the TBS about 4 to 5%. Denosumab, very good for the BMD for increased bone density, but only improve the TBS about 2% or so. Bisphosphonates is also good to improve the bone density, but it doesn't, significantly improve bone quality. And here is a hormonal replacement therapy. It doesn't do anything. It might actually do some harm with the bone quality. On the other hand, on the other side, you can see glucocorticoid doesn't, decrease dramatically the bone density, but it decreases the TBS. It decreases the bone microarchitecture. Other thing you can get from the DEXA is the vertebral fracture assessment, both the patient on a lateral position and take X-ray film, you can detect vertebral fracture. And this is very easy. Vertebral fracture assessment doesn't add time or radiation exposure, and it's very simple. You just need to put the patient on lateral position and take a film. And while you're doing that, you can also get some impression about the cardiovascular calcification, aortic calcification. Here, there is different score. There is score of 24 and the score of 8. Every single lumbar vertebrae here, we have 1, 2, 3, 4, and each one has anterior and posterior. Then they calculate, then they give you a score. So it's very important to use when you order DEXA, not only focus on BMD, which is very important to measure, but also focus on the trabecular bone score, the vertebral fracture assessment, and the aortic calcification. Just with one exam, you can get many birds with one stone. Let's talk a little bit about the quantitative CT exam. So quantitative CT can be a good alternative to DEXA in a subgroup of patients, especially in those who are very small or very large patients, because DEXA is less sensitive in these patients. Because as we said, DEXA scan is 2-dimensional. PUCT scan is, 3-dimensional. It's a volumetric. The DEXA scan is aerial measurement. Here is volumetric measurement. So the DEXA scan gives you the bone mineral content and bone mineral density gram per square centimeter. Here it gives you by cubic centimeter because it's volumetric. And also it's good in patients with advanced degenerative spine, because these patients, they give you false positive results with the DEXA scan. And in very obese patients, because the fat behind the vertebrae can also give you positive, false positive result in DEXA. So all of this DEXA limitation can be solved here with the QCT. And it might be, better to monitor treatment with QCT, because the changes here appears faster in the QCT. It can pick up the changes after start patient on anti-osteoporotic medication or osteobuilder. So it predict and it follow the response to treatments better. So the quantitative CT increased precision of the BMD measurement, and the slice thickness goes down to 1 millimeter, usually 1 to 3 millimeter. It's a volumetric. It differentiate and distinguish trabecular from cortical bone. DEXA scan cannot do that. The major limitation is the cost and the radiation exposure, of course. So there is a newer technique called high resolution peripheral quantitative CT. So it's another CT, but with high resolution image. So you see the difference here in the image with this high resolution, because it goes down with, especially with second generation machine, down to 30 micrometer millimeters. So in the regular QCT, we're talking about 1 to 3 millimeter. Here we are talking about, micrometers, so different, spectrum, and because it's high resolution. It's again volumetric, differentiate cortical from trabecular bone. Actually, there is trial that we can use this HRQCT as a virtual biopsy. So instead of doing biopsy, bone biopsy for our patient, we can replace it with this high resolution image. You can do a bone strength studies like finite element analysis. I'm not going to talk about the bone strength studies today, but of course there is other study that can check on the bone strength that it can be done with HRQCT. It's usually peripheral, so it's mainly for the radius and for the tibia. And single scan gives you very small amount of radiation exposure. When we talk about the regular CT, we're talking about milli units. Here we're talking about micro units, so the radiation exposure is very low. And here you can see very nice image. You can see the cortical bone, you can see the trabecular bone, then you can zoom and see how the trabecular bone looks like, the connectivity between the trabeculae and the thickness of that trabeculae. And you can see, of course, you can appreciate here in this patient with osteoporosis, and here is a patient with normal, HRQCT exam. You see the difference in the cortical and in the trabecular bone. Here is another image for vertebrae that is compressed in osteoporotic patient, and you can see the difference in the volume with the CT exam, and also with the trabecular number, connectivity, and the density. This is a study that was done in CKD patient, was published in JSON 3 years ago, and they tried to replace, they did bone biopsies and they did high resolution, HRQCT, and they did bone biomarker, bone resorption, and bone formation biomarker. And the conclusion was the bone biomarker, of course, the problem with HRQCT and all images doesn't give you the underlying pathology, if it is high or low turnover, how you treat that. So, but bone biomarker can give you impression about the high or low turnover bone disease, because there is a bone resorption marker and bone formation marker. So the combination of this bone biomarkers and HRQCT may have potential to replace bone biopsy. So hopefully with improvement of radiation technology and using higher imaging technique, we can do less bone biopsy and can diagnose the bone disease non-invasively with combination of biomarkers and high resolution image. The last thing I want to talk to you about, that when you have a patient who was taking steroids for any reason and is coming with some pelvic pain or sometimes even back pain, don't miss the boat and try to do MRI, to diagnose avascular bone necrosis or hip necrosis. You can see here in the regular X-ray, it's very late. You can see this crescent sign when you put the patient in a frog leg lateral position. But here is the MRI, the T2 MRI. You can see the low signal and the high signal intensity line with the crescent sign. Of course, if you pick this early, so early the X-ray, the regular plain X-ray will be normal, but MRI will have increased the marrow edema that can pick this diagnosis early. Then if you diagnose the patient in stage 1 or stage 2, you can do non-invasive or minimally invasive technique like cord decompression. But in late stages of avascular hip necrosis, usually these patients with collapse of their femur head, they need the hip replacement. I will stop by here and I will be happy to try to answer any question, and you have my email address. So please email me for any concerns, questions, and thank you so much for listening.